Targeted therapies are a key type of treatment now, especially for non-small cell lung cancer. These mutations occur much more frequently in adenocarcinomas and or in patients with light or never smoking history, but that is not absolute. And this is why, for me, I think molecular testing is incredibly important for patients, all patients with non-small cell lung cancer. What I have listed here is for patients with stage 4 metastatic non-small cell lung cancer. Here are some of the different targeted therapies for a specific molecular alteration. You see there's an incredible list. So in that second row in that light blue, these are the current approved frontline molecular alterations, meaning if your cancer, your loved one's cancer has one of these molecular alteration, we believe that any number of the therapies in the green box below is superior to chemotherapy and or immunotherapy in terms of your frontline treatment. This has been, shown in innumerable clinical trials. On the far right column, you'll see the orange molecular alterations. Now, these are molecular alterations for which we think in the front line, it is still possible, it is still better to receive chemo and or immunotherapy if appropriate. But in the second line, instead of doing chemotherapy, you can get one of these targeted therapies. Now, just as an example of how quickly we are moving in this space, I submitted this talk, about 2 weeks ago, and already this is now outdated because as of last week, there's been yet another approved targeted therapy in the second line for something called an NRG fusion. And the drug, and I'm probably butchering the name, is called zenocutuzumab, and it's approved for patients who progressed on frontline chemoimmunotherapy. However, targeted therapies really are not just for stage 4 anymore, and this is going to be the focus of my talk today, is that molecular testing, understanding what are the DNA changes in the cancer, it's not only just important for patients with metastatic cancer, but also for patients with earlier stage cancer. The focus today will be on EGFR and ALK, for which we have the predominant results from clinical trials, but there is more work that is being done in other molecular subtypes. So if we think about first for patients who have what we consider surgically resectable non-small cell lung cancer, meaning a thoracic surgeon feels with confidence that they can remove all the cancer, what is a typical process is on the left, the surgeon not only removes the primary lung tumor, but also should do an extensive evaluation of the lymph nodes, the neighboring lymph nodes, to see if there's any evidence that the cancer spread to these lymph nodes. What then happens is that specimen is taken to the pathologist, and they will look under the microscope to help us identify the specific subtype of non-small cell lung cancer, tell us if the margin looked good, meaning that all the cancer was removed, and more importantly, do we see any evidence of lung cancer in any of these lymph nodes that were removed? Depending on those findings there, and now, of course, I'll explain why molecular testing is incredibly important in this arena. There are really currently 3 major options. We can consider observation, meaning sometimes patients with incredibly small lung cancers, you don't need anything more other than continue close follow-up with scans. You may be offered chemotherapy. You may be offered immunotherapy after the fact. And today we'll talk about why you should maybe be offered targeted therapy as well. So the first study I want to highlight is the Adaura study. So this is patients who had an EGFR non-small cell lung cancer, and this is very important to note that this is specifically for the sensitizing or common EGFR mutations that Dr. Roto showed in her lovely graph of the different types of EGFR mutations. And these are patients who had stage 1 to 3A non-small cell lung cancer who underwent a complete surgical resection. Brain imaging was also done to make sure that there was no evidence of cancer that spread to the brain, which is incredibly important in lung cancer. And then patients could either have received chemotherapy if their oncologist felt it was appropriate, or go straight onto this study. Patients were then randomized in a 1-to-1 fashion to receive either the osimertinib, Dr. Roto talked about is Tagrisso, which is used in the front line in stage 4, or they can be randomized to receive placebo. And these patients received treatment for up to 3 years, and they were continuously followed with scans. What the study showed is that these are the overall survival curves, is that at 5 years, there was statistically significantly improved 5-year survival with osimertinib of 85% compared to 73% with placebo. This is in the stage 2 and stage 3 patients. But even if you add those stage 1 patients, so these earlier stage patients, you see that there remains a survival benefit for the addition of osimertinib versus placebo. And this was approved by the FDA in December of 2020 for patients with surgically resected sensitizing EGFR non-small cell lung cancer. In a very similar study, here we have something called the Alina study. So they took a very similar population of patients, the stage 1 to 3A. And these were patients who then had ALK positive non-small cell lung cancer, another probably our second or third most commonly found mutation. In this situation, though, patients were randomized to either receive the alectinib, which is a second generation ALK targeted therapy for 2 years, or they were randomized to receive chemotherapy for every 3 weeks for 4 cycles, as is considered standard. And these patients were also followed for recurrence. And here we see the progression-free survival because we do not have the overall survival as of yet. But you see that as compared to chemotherapy, alectinib did lead to a significantly higher duration of time in which the cancer has not recurred. You'll see that that is 44 months with chemo and not yet reached with alectinib. And so even though we haven't seen the overall survival results, I think this data is certainly very, very promising. And in fact, alectinib was approved by the FDA in April of 2024 for surgically resected ALK positive non-small cell lung cancer.